Hi, it's Dr. Centeno, and I'm going to try to share my presentation today full screen, just because I'd like to be able to write on the screen. So hopefully this works. I've got an assistant out there who's going to try to see if that is coming through on your side. And while we're waiting for her to check that out, today's topic is, do you have internal jugular vein compression, and what does that have to do with CCI, or craniocervical instability? Now, this is a really important topic because I've seen an awful lot of patients lately who are very concerned about possible internal jugular vein compression. These are patients who probably have CCI. And in general, this is a story like many stories in medicine, where we have to be careful how we get to a diagnosis, and that imaging is a two-edged sword. Imaging, on the one hand, can be extremely helpful, but when that imaging isn't put together with the other parts of the puzzle, it can also cause more problems than it's worth. And so that's really the moral of this story today. So I'm going to get into this. This will probably be more about a 20-minute presentation, which is a little bit longer for me. But I think this is such an important topic to explore in depth and I want to make sure that people understand what's going on here. So again, the title, do you have internal jugular vein compression? What does that have to do with craniocervical instability, or CCI? So let's get into some anatomy first. So we have the front of the neck here, and the back of the neck, and the side of the neck. Hold on a second here. I'm going to try to get something where I can draw. Okay, so we have the styloid process out here, and we've got the internal jugular vein coming in here. And if we look at the side view, what we're going to see here is the styloid is there. And then we've got this lateral aspect of C1, which can be close to the internal jugular vein, which is running right here. So that's really what this whole topic today is about, because it's possible to see some compression at this level that can be due to craniocervical instability, because if C1 moves forward there on the right, it can possibly compress that internal jugular vein, especially if the styloid has a stylohyoid ligament coming out this way that's calcified. Again, there's really no such thing as an elongated styloid. There is something called a calcified stylohyoid ligament, and that can lead to what appears to be a long styloid. So that's kind of the crux of the issue. And just this makes it a little bit clearer here. If we look at this side view here, we've got the skull way up here, and the skull is linked together very closely depending on the depth of this 0-1 joint. But in general, the skull and C1 tend to move together. So if both of those guys come forward, they can push this little transverse process of C1 into the internal jugular vein and cause some compression. And if this ligament that attaches here is calcified, that may cause some compression there. Now, this is a more complex view here from above than you're probably used to seeing. But we have here the transverse ligament coming across this way. This is the dens back in here. And then we've got the alar ligament. This particular anatomy picture has it a little wrong. Most people's alar ligaments come up forward like this. So not quite sure where they have it in that direction. And then this is the vertical part of the cruciate ligament, which is also part of the transverse ligament. And you can see that kind of what's happening there. And now I'm going to move to another slide. But if we have the internal jugular vein here, and we have this transverse process, if this comes forward, it can mess with that vein. So I took what was there and I abstracted it so it's a little bit easier on the eyes to look at. But you can see here that we have this transverse process of C1 on either side. We can have a styloid here in front of the internal jugular vein. And then if these ligaments are loose, the transverse ligament or the alar ligament, what can happen is that this whole thing can slide forward on C2, and then that can bang into the internal jugular vein. So just like I've outlined here, that compression can happen there, and this is a cross-section looking from above. So the big question then comes into, we have all these CCI symptoms, and we know that that's headache, dizziness, neck pain, imbalance, and lots of other symptoms. And we know that that can cross over with intracranial hypertension symptoms, meaning that you've got some blockage at the internal jugular vein. And this is actually from this paper that was recently published in 2020. And it talks about the main symptoms of patients who presented with internal jugular vein stenosis that were symptomatic. And I've made it a little easier on the eyes again here. And basically what I did is I took all those symptoms and how often they were reported, and I've adjusted the size of the word to represent that. So insomnia was the #1 symptom. Head noises and tinnitus were kind of #2 symptoms. So most patients had these 3 symptoms, or 2 of these 3, insomnia, head noises, tinnitus. Fewer patients actually had hearing impairment, but that was in there. And then the absolute fewest patients had headache and neck pain, which are some of the presenting symptoms of a lot of my patients who believe they have internal jugular vein stenosis. So I've got to be really careful here that the main index symptoms for internal jugular vein stenosis or compression aren't necessarily headache and neck pain, even though those are 2 presenting symptoms that a lot of patients have who then get tested for this. So let's look at testing. So really the gold standard is CT angiography or venography. So all that means is you do a CT scan and you inject contrast either into the arteries or veins. And this can be done either static or with a head turn. But if it's done with a head turn, special orders are needed to get that done. MRI is often not real accurate because you mostly see what's called a flow void where this is. So you're not really seeing the veins real accurately on MRI. And ultrasound, I think, is going to be the least accurate, simply because it's highly operator dependent. So if I ultrasound the internal jugular vein and I don't have that probe just perfectly, or if the patient moves slightly, then it comes out of my field of view and I can't see it. So of these, it's going to be CT angiography is really the first. Now you can also try to do an MRA or an MR venogram, but again, going to be harder to do things like head turn with that and not necessarily the gold standard right now. So this is what this looks like. So this is a CT venogram here. We see the internal jugular vein. It seems to be getting compressed moderately on this side. So that's its outline. So you can see it gets a little smaller where I have it drawn with the dashed circle. This is going to be that transverse process of C1, and this is going to be the styloid. Now the same patient on the other side has got a little bit more going on here. And we can see some compression here that would probably be more in the moderate to severe category. But you also notice that there's something here that's showing up. and that's this guy here. This is called a collateral. And that means that whatever's not going this way because of compression is now going this way. And that's a common thing in the body we're going to talk about because it's one of the things that makes this a very hard diagnosis to pin on somebody unless we go in and surgically open all of this up and see what happens. So right now, the biggest treatment for this is styloidectomy with or without shaving down the front of C1. But that's a major surgical procedure. You know, we're dissecting out the neck, we're damaging certain things when we go in there, taking out that calcified stylohyoid ligament, destabilizing the anterior neck, et cetera, et cetera. And we're doing all of this in very close proximity to that internal jugular vein, which can be damaged during that procedure. So while this may need to be done, it would clearly be towards the end of a list of things that you would want to do if you thought you had this problem. Now, here's where this gets really complex, and it's critical that you pay attention to this part, because we got a lot of physicians out there making this diagnosis of internal jugular vein compression, and they are assuming that that is absolutely abnormal and causes symptoms 100% of the time. And patients assume that too. And I understand why. You know, you don't have an answer for why you have these headaches. And all of a sudden someone does a test and they say, aha, that's it. If we get rid of that, then you're going to be fine. The problem is that's probably not true, or it's probably not nearly that simple. So in any test, we need to make sure that we understand the false positive rate, meaning how many patients have that positive test who are totally normal. Now, this is a funny way to look at false positive and false negative rates. A false positive would be this guy saying, this doctor saying you're pregnant. Obviously, this guy's not pregnant. So that's a false positive. And so that's what we're trying to rule out here, false positive. So in order to do that, we need to know how many patients without this problem of intracranial hypertension causing symptoms have internal jugular vein compression. And this is why, if you've often wondered, well, why does Dr. Centeno use DMX to diagnose CCI? Some of these other guys use other things. And that's because there was a large study that was done about 2 years ago that looked at the normal rate of C1, C2 overhang in about 70 some patients versus 119 patients who had this problem. And what they found was that there was only a 5% chance that more than 3 millimeters of overhang of C1, C2 was normal. So that's why we use that test, because we have to have something that we know isn't often found in patients without the problem. And even with that, we've got to get to, for CCI diagnosis, symptoms that match, a cause that makes sense, an exam that localizes to the upper neck, and responses to treatment that fit. So let's ask this critical question. And if you think you have this, you need to ask this critical question. So how often is internal jugular vein compression seen in patients who have no symptoms? Well, the answer is quite a bit. And this is the problem with this diagnosis. So that woman you saw had one-sided moderate stenosis there. So I showed you that CT venogram. The problem is that moderate stenosis was seen in between 1 in 3 and 1 in 4 patients who don't have intracranial hypertension at all. In fact, their necks were imaged for another diagnosis entirely. And we're not talking about just a few patients. We're talking about 108 patients who had CT angiography to rule out other problems. So they clearly didn't have internal jugular vein compression. They were looking for things like a blocked carotid artery and the symptoms that go with that. And severe stenosis on one side, like she had on the other side, was found in about 1 in 4 patients on the right and about 1 in 5 normal patients on the left. Most common area of compression was the styloid process. That's interesting because that's what we're taking out right now. And severe bilateral was seen in 1 in 10. So again, pretty high number of people had severe bilateral compression and no symptoms of intracranial hypertension. So this is a pretty critical thing to understand. So let's pause and let that sink in. So more than 1 in 4 normal patients has a moderately compressed IJV. They do not have intracranial hypertension or the symptoms associated with it. This would be 1 in 4 people who we pick off the street who might need a CT scan to look for something like carotid artery problems. 1 in 5 normal patients has a severely compressed IJV, and 1 in 10 had severe bilateral IJV stenosis. And their conclusions were, hey, this is pretty common, so we shouldn't get too freaked out when we see this stuff unless we can link it to symptoms. So how could that be normal? This doesn't make any sense to me, right? You're probably saying to yourself, I don't get this. The doctor said it was abnormal. They want to operate on me or put in a stent. So how does that work? Well, it works through collateralization. We saw it on that patient's CT scan. That is, when you've got normal flow, everything is good. But when that flow is blocked, the body creates other ways for the blood to get there. So you might have severe internal jugular vein compression like this one, but what's happening is the body creates veins around that blockage, and that's what occurs. So we have to be very, very careful in being too freaked out when we get these reports showing internal jugular vein compression. So how can you tell normal IJV compression from symptomatic or intracranial hypertension? Well, symptoms that match would be good. We already went over symptoms. It's not generally headaches and neck pain, but that's possible. And I've seen a few patients who do have legit fluid backup in the brain on their MRIs. So that would put a little bit more weight in that direction. But most of the patients with IJV stenosis do not. And regrettably, the only way we're ever going to be able to figure this out is to do the surgery and see if the patient gets better. Obviously, that may be what you need to do, but you want to put that at the end of the treatment because that's the most invasive thing possible. So here's a case to consider. This is one of my patients the other day. Now, this guy has an increased atlantodental interspace. So that's the amount of distance between the dens and C1 here. And so that indicates a lax transverse ligament, which lives over here. He's also got some increased fluid in the brain. This is more fluid than he should have in these spots. So at the end of the day, he may have internal jugular vein compression. However, since we know he has CCI, obviously it would make sense to treat that non-surgically first. And then if he has no results, we can do a CT venogram to look for IJV compression. And because he has the backup of fluid in his brain, it may or may not make sense to do that procedure where that area is opened up. But again, that's that ladder of invasiveness that we always talk about. And if it's this big ladder, you start with less invasive things down here, Then you go to something slightly more invasive, then slightly more invasive, and more invasive, and more invasive. So if we're talking about things to do for this guy, something like PICL is going to be down here, and opening up his, or doing a styloidectomy, if that's the problem. So a styloid surgery is going to be way up here. It is not a first line of treatment at all. And then obviously something like an upper neck fusion is going to be up in here. So we keep patients safe by exposing them to the least invasive thing that's the most likely to work or has a shot at working. And if that doesn't work, we go up that ladder of invasiveness. So in conclusion, just because you have IJV compression doesn't mean it's causing your symptoms. If you have CCI, get that treated first without surgery. If that doesn't work, you can always go to the more invasive things. So I know this is a little bit longer than I normally do, but this is such an important concept. I want to make sure that everyone understands that just getting a CT venogram that shows that you have some IJV compression is not the end of the world. And it certainly provides another piece of helpful information, but it is not a rationale for an immediate surgery to open that up. So I'm going to go take some questions now. Let me pull this down. Okay, so I think I got lots of questions. I couldn't see them while this was up. So I will start answering those questions. Regenix, submitted advanced by Harry Winston. Does jugular vein compression always cause symptoms? And if so, what are they? But I find most doctors always have another explanation for my CCI symptoms, and those explanations usually involve surgery. So Harry, hopefully the presentation answered that for you, but obviously the answer is no. Internal jugular vein compression doesn't have to have intracranial hypertension symptoms. Steve, awesome diagrams. If there's a rotation of C1, then the digastric muscle will also compress the IJV structures too. Yes, Steve, and in fact, while I was going through that, I was going to add yesterday a rotation of my little diagram there yesterday. I didn't. So you're absolutely correct that you can have not only forward movement, but rotation causing a similar thing. And clearly that's what that woman had whose venogram I showed, because one side was more compressed than the other. So thank you so much for bringing that up. Submitted advanced by Camilla Brown. Is this diagnosed with an MRI or is there some other test needed? One doctor said this was my issue and referred me to a surgeon, but no tests were done. I didn't go as my husband. I decided it was a radical step, but no test to confirm the diagnosis. Yeah, so the main diagnostic test for IJV compression causing headaches, intracranial hypertension, etc., would be that CT venogram. And you can do an MRI venogram. I don't think that's quite as good because you don't see the bones as well. And you can't really do any head turns and other things like that because it takes a long time to get that signal. And I would agree, we don't really have a test to say for sure that this is causing your symptoms. Ultimately, the final test is to decompress it and see if you get better. Let's see, Mark, I had a procedure on my lumbar SI joint 3 weeks ago. My post-procedure instructions say, call if there's excessive perspiration, maybe at the injection site. I'm not quite sure what you mean there, Mark. I have this, however, I did not start after this procedure. It started after a procedure about 5 years ago. If you can give me more information there, are you talking about perspiration, like sweating there, or something else? Because I'm not quite sure. So please clarify that, and happy to answer your question. Steve, so the IJV compression caused drainage issues and then higher intracranial pressure issues, and drainage often issues like mastoid inflammation, even mastoid air cell application too. If the IJV compression does not develop collaterals, then yes, you can get backup of pressure. But if it develops collaterals, meaning new veins that go around the area, then there would be no backup of pressure or increased pressure. And as far as mastoid air cells, it shouldn't impact that at all. I have bilateral IJV compression, and on the right side, it has caused a small clot. It was identified via ultrasound, but I've been offered no treatment or further investigation per the usual mainstream docs. Just shrug. I've CCI. I'm looking forward to hearing what you said. Yeah, so Rachel, if there's a small clot there, probably best to get a CT venogram and see what's going on there. If there's a clot, the standard thing would be to anticoagulate you, i.e. to put you on medications to thin your blood. So that's the standard treatment. Now, I'm not quite sure when that was identified, and we generally don't use ultrasound to look for IJV compression because it's not as reliable as a CT venogram. So if you've got an issue and you've done a telemedicine consult already, then we can write for a CT venogram and see if that clot is still there or if the body's absorbed it. Obviously, if it's still there, that's something that you may need to have anticoagulation for. If it's not still there, then no harm, no foul. And realize that CT venogram would be the way to go. And happy to write that order. If you've seen one of our docs, they can write that order for a CT venogram to check that out. Does shaving of C1 affect CCI? Should this be considered if styloids are already removed, or should CCI treatment be a better option versus shaving of C1? You know, let's go back to our ladder, because this is a good question for that. So just like I was talking about before, we have this ladder of invasiveness, right? And that is, you do the least invasive thing that has a shot at working. And then if that doesn't work, you do something more invasive. Now, shaving down C1 is incredibly invasive. I mean, that's a huge surgery. There's no other way around that. There's lots of stuff up here that will be impacted, including the ligaments that attach to C1, the muscles that attach to C1. And so that's something you definitely don't want to mess with unless there's no other way to do that. So if you've got CCI, you'd want to treat the CCI with something like PICL first. And then if that didn't work, you could always consider some sort of surgery to shave down C1. But again, that's going to depend on what that CT venogram looks like now. So if you've had the styloids removed, then maybe it's time to get a repeat CT venogram, take a look at that and see how that's looking, right? Because if it's looking fine and there's flow through there, you wouldn't want to shave down C1 at all, regardless of what's happening, unless you were convinced that C1 was causing additional compression. Stephen Cloud. So if there's more than 50% compression or even bilateral IJV compression, as common with a syrinx, is that more relevant? No, the syrinx really shouldn't make too much a difference there. We see lots of syrinxes on MRI. So syrinx, just so everyone knows, it's when the little tiny canal in the middle of the spinal cord gets a cyst or a fluid balloon out, that's called a syrinx. If it's severe, it can cause central cord syndrome, which is a very clear collection of things. But so ultimately, just realize that they shouldn't be directly related because you're going to get collateralization with that IJV compression, meaning that the fluid's going to go around that area. Amy, Dr. Centeno is a favorite doc for me, who I saw back in 2002. Terrible what was done to me. Thank you, Amy, for saying that. Appreciate that. Steve, that bilateral IJV compression more than 50% is seen with syrinx cases. It seems to be from another C1C2 rotation of tethered cord. Is that relevant? Again, tethered cord should have nothing to do with this discussion, a totally different concept completely than IJV compression. The syrinx shouldn't be related to that either. So these are kind of different silos of things that generally don't overlap and aren't related. Steve, if there's obvious signs of drainage problems like chronic mastoid inflammation with bilateral IJV compression and a syrinx, is that relevant? You know, Steve, I'd have to look at what you're talking about there as far as chronic mastoid inflammation. The mastoid is a bone. Inflammation in the mastoid bone could indicate perhaps upper cervical problems, but wouldn't necessarily be related at all to IJV compression. Justin, I had a consult with a neurosurgeon and he had me press into the area on my neck at my right styloid process. Doing this triggered a flare from my neuro symptoms. Pressing into other places of my neck did not. How about you to consider that type as a test or a diagnostic? Not much. Let's look at that though, because I think that's important for us to think about at least. So I'm going to put the whole thing up again here so that we can look at that. And okay, so if we go to this third slide here. So the styloid, let me get my little pen back. So the styloid is here. Now, it's going to be pretty hard to just put pressure on the styloid. Basically, I'm going to be putting pressure in this whole area. Now, there's a couple things that could happen there. One is you could compress, if you had it just right, the internal jugular vein. You could also push on the transverse process and rotate the C1. And then you could end up pushing on a ton of other structures in front of this. So I would say that it's certainly a helpful piece of information, but it's not diagnostic in and of itself. So let me see if I can get out of that now. Okay. Justin, can the glossopharyngeal nerve block be used to determine if a styloid issue is causing symptoms? Yeah, I mean, that's a little bit more information, again, because the concept there is the glossopharyngeal nerve might be getting trapped in there and irritated. And so you can do a block there. Now realize that a glossopharyngeal nerve block, just so you understand it, needs to be done usually under x-ray guidance. It's not so easy to see the styloid under ultrasound. So that's an x-ray guided block. Now, if someone's just doing that blind in the office, then no, that's not a valid block. But if someone does an x-ray guided glossopharyngeal nerve block and the appropriate areas go numb as a result of that block, and that gets rid of a lot of symptoms, then you've got, again, another piece of information that moves in the direction of perhaps a styloidectomy is appropriate. But again, one piece of information by itself doesn't get you there at all. Rachel, thank you for talking me off the ledge. Haha. I will stay the course, which is treat the CCI. Hope that IJV compression is downstream of that. Yeah, Rachel, that's what we all hope for, because again, we all want to expose patients to the least risk possible to try to get some results. And that's how you keep people safe. If you start exposing them to the most invasive thing you offer all the time, then that's how people get hurt. So we try to keep people safe as much as possible. Justin, my symptoms started from neck trauma, severe twisting and cracking. Is it possible that there's some scar tissue that's blocking the veins or affecting nerves in my neck? Does scar tissue show up in a CT scan? You know, Justin, scar tissue won't show up on a CT scan in general. Usually a CT is really good at looking at bone, but not really at looking at soft tissues. Even on an MRI, it can be difficult to see scar tissue, especially in this area of the neck, because there's a lot of moving parts. You got a lot of vessels that are pumping and moving, which are disrupting the MRI signal that you're trying to compensate for, et cetera, et cetera. So as far as diagnosing whether there's scar tissue, that might be something like a hands-on physical exam combined with ultrasound. And even then you may not find it, but that's generally would probably get you closer to being able to see it or find it. Adina, if I have compression of the IJV in time, also the sinuses on the compressed side become hypoplastic. I think what you're talking about is whether or not the sinuses can back up on that side, and the answer is they can. So that's a possibility. But again, the only way to see if the IJV is causing that versus something else would be to do the surgery to decompress the IJV and see if that gets better. And obviously, that's a more invasive way to go. Mark, yes, seat in the area, injected S1 joint lumbar. Was it from this treatment, from a treatment carrying medical? Not sure, seat in the area, but I understand, I think what you're saying, it sounds like that area has a different sweating pattern, and that could be due to some injury to the autonomic nerves in that area. So that's possible. Justin, can collateralization be seen on a CTV? If so, will they make it easier to determine if IJV compression is causing symptoms? Well, it doesn't get you to symptoms, but it certainly gets you to something you should ignore. So I'm going to put that screen back up like I had it, because I want to show you that collateralization to make sure you understand what I had showed before. So let me share the screen here, and then go to that, and then get my little pen back. So you can see on this side, she's got just moderate compression. So this is the moderate compression I'm outlining. So probably not a big reason to develop a lot of collateralization. Now on this side, she's got severe compression. So this is what it looks like here. That's the IJV that I'm outlining. And you can see she's got active collateralization. So instead of this stuff or the blood and fluids going down this way, they're going this way. You can see the collateralization right there. So they're going just heading a completely different direction. And yes, collateralization can generally be seen if it's looked for, and sometimes it's not so obvious because there are a huge number of veins that we're talking about here, and those huge number of veins are all over the head and neck. So something can also just take a different route or get routed through those other areas. Paul Diffusco, hello, Dr. Centeno. Could the sensation of fluid in the skull be caused by a fluid backup, in turn caused by IJV compression, maybe any adjustment turning the vertebra too far? It's all possible that could. So again, IJV compression can cause a sensation of fullness in the head, is usually how it's described. As far as fluid backup, I'm not quite sure what that feels like, but I think you're talking about a fluid filled or pressure sensation in the head, and it could cause that. It's just not as likely to cause that as other things, given what we know about what's been published. Laura, hi, Dr. Centeno, what are your thoughts on nerve blocks for continuing occipital neurology even after PICL? Can the injections cause damage or do more harm than good? If there's continued issue with the occipital nerve, then the occipital nerve can be treated to break up scar tissue and put some platelet growth factors on the ground there to help the nerve. So if that continues, that may need to be treated separately or at the same time. Thank you, Amy. Appreciate it. Steve, it would be fair to say that bilateral IJV compression will have 50% commonly seen with the Syrinx and EDS cases, then, or is the presence of caudal veins a factor there too? I'm not sure what you're saying there, Steve, or what you're asking. I think the whole point of this talk is, at the end of the day, if you've got IJV compression, it's not uncommon. Let's go back to that. I want to go make sure that I drive this point home, because this is really an important one. So I'm going to put that slide back up because I think this is critical that everyone understands this particular one. So let me share the screen again. So I'm going to put that back up here. Okay, so let's get the highlighter out this time. Okay, so moderate stenosis, which is what you're describing, I believe. So moderate stenosis here is seen in 1 in 3 to 1 in 4 patients who are normal. They do not have intracranial hypertension. They do not have any symptoms of intracranial hypertension. These are people going around living their lives who got a picture of their neck for another problem, and they ended up having this, and they don't even know it. Severe stenosis was found in 1 in 4 to 1 in 5 patients. So again, it's incredibly important to understand that at the end of the day, this is a common finding for patients who don't have any symptoms and who definitely don't have intracranial hypertension. So I know it's hard to conceptualize that people may have abnormalities on their imaging that mean nothing at all, but that's one of the challenges in clinical medicine. What should we pay attention to and what should we ignore? And based on that study, we should be ignoring more IJV compression than we should be paying attention to. So just make sure that you understand that, because that's what that study found. Yes, yeah, I think I got that. Floyd, can accurate foramen cause, or an arcuate foramen cause permanent unsteadiness, or is only causing vertigo when the head is turned? Yeah, so let's look at that concept of an arcuate foramen, just so that everyone knows what we're talking about here, Floyd. Let's go to get a picture of this. Okay, this is a good enough picture here. I'm going to try to blow that up for you because it's always a little hard to see this, I'm sure, on a little screen. So let's do this, let's do that. And let's go share my screen again. And then let's make this bigger. Okay, so an arcuate foramen just means, and let me get this again. So arcuate foramen just means that the vertebral artery goes through an extra little arch thingy here. Sorry about that, guys, it's my fault. Okay, so the vertebral artery goes through this little extra bony arch. So normally the vertebral artery comes through here. There's a little hole in this transverse process of C1, and then it goes this way underneath the 0-1 joint. So remember when I've said that you've got to get someone who has a lot of experience in injecting the 0-1 joint. This is the skull here in the occipital bone. And this is the 0-1 facet joint. Well, look where this vertebral artery is. It's right below that joint. So if I don't put the needle accurately right here in that 0-1 facet joint on another topic, then I could inject in the vertebral artery, and that vertebral artery supplies blood to the back of your brain. Now, the arcuate foramen is this thing here. Most people don't have this extra bony arch here. Just maybe 1 in 10 people or so do. Now, an arcuate foramen doesn't necessarily cause any problems. Now, it could mean if you had instability at C1, and that C1 is moving around too much because of the loose ligaments, then it could cause more trauma here, all things being equal, on the vertebral artery, because now the vertebral artery is kind of having to go through this extra tunnel on C1. Normally, it only goes through this tunnel on C1. So at the end of the day, this is it's not an important issue unless there's instability, and then it may be. And then also, it's a great way to look at how difficult the C0, C1 injection is and why a lot of doctors don't do it because they're afraid of hitting big red down here because that's a bad day for everybody. Okay, so we'll get back to questions. Steve, is the fact that IJV compression also indicates carotid sheath compression, so the internal and external carotid arteries, vagus nerve, present are a cause for concern too. Does IJV compression indicate carotid sheath compression? Well, let's do some research on that so that we can all get on the same page here. Okay, so let's look at the carotid sheath here. And again, I'm going to try to blow this up because it's not real. It's not real big, and I'd like to make it full screen so we can all see it. Okay, so let's get back to that. Let's share the screen here. And let's go to here. Okay, not the best picture. It's kind of grainy, but it'll work. Okay. So what we're discussing there is if you had a problem with your internal jugular vein, could that also impact other things? Like this, we talked a little bit about this glossopharyngeal nerve here that could be a problem if the styloid here and the C1 there is causing compression. So that's where that whole glossopharyngeal nerve block thing comes in that we were talking before, and that's commonly done in Eagle syndrome. And really what you're seeing here is lots of different nerves, right? So we've got the internal jugular vein here. We've got the vagus nerve here going down that way. So certainly the intermittent compression of the vagus nerve can cause things like a rapid heart rate or POTS-like symptoms, which would be the theory of why that's happening with C1-2 instability, because C1 is banging into this area. And that's the ultimate theory why you might want to take out the glosso or the styloid or the stylohyaloid ligament there, the calcified ligament. But ultimately, there's a lot of target-rich stuff in here. So we've got to be careful, because if we injure any of this, this person is permanently jacked for life. So internal carotid artery obviously provides blood to the brain, going that direction. So very, very careful here not to do anything that would mess this up. So again, the answer is theoretically, you could see issues like you're describing, and that then brings in the glossopharyngeal nerve, that then brings in the vagus nerve, and all the more reason that if you've got CCI, try to get that stabilized non-surgically first. And then if that doesn't work, you can look at doing procedures that operate in the vicinity of this extremely important area. But at the same time, we don't want to operate in this area if we don't have to, because that's obviously ups the risks for our patients. Yeah, Mark, I figured that. Thanks for that. Steve, CT image you're showing, is it fair to say there seems to be excessive CSF in the image? So another possible indicator of the CT image. Did that show excessive fluid in the brain? Didn't show any fluid in the brain. So no, we're not seeing any excessive fluid image in the brain on that CT image. We generally won't see fluid in the brain at all in the CT image unless we do something to light it up. I think you're actually seeing the skull there. So let's make sure we understand that, because this is important. So if we go to share the screen again, we'll go to this, and we'll try to blow up that one. So I think you're talking about this. Now this is all bone. So this is bone and it's skull. The guy doesn't, this person doesn't have a thick skull. What you're seeing is the slice through the bone is off on the side. So it's going through the area of the skull that curves. So this is bone and not fluid. Now, sure, if this person had that much fluid in their brain, then yes, we'd have a bigger problem on our hands. They would need a ventricular shunt or some brain shunting. But no, that's not what you're seeing there. That's actually the skull. Cian, hey doc, can we arrange telephone consultation? Please, want to fix my issue. Had enough, thanks. Yeah, so Cian, that best thing to do is let me put Carla's information down in the comments here. Carla is my assistant. So she would be the one to reach out to directly. So I just put her email address in the comments below. And if for some reason you can't see that, let me know, but I just put it down there. Reach out to her directly and she can help you with that. She's my assistant and she can get all that kind of stuff done. Adina, is the flow through collaterals fast and efficient enough in order to compensate IJV compression, or with some delay, can they generate symptoms? Yeah, Dina, that's a good question. I would assume that we probably have a little bit of both going on. We probably have most people who can compensate adequately through collaterals, and some people who maybe can't, and maybe those are the people who have symptoms. Again, we don't know who's which until we take the incredibly aggressive surgical step of trying to decompress that area. So that's the difficulty. But yes, that certainly could be the case. So yeah, how does one know if he has an elongated styloid or a ligament issue in the neck? It's confusing. Yeah, so sometimes you can see an elongated styloid on a regular X-ray. Sometimes it takes a CT scan to see. It's not usually seen as much on an MRI, regrettably, because MRI isn't quite as good with picking out bone like a CT scan can pick out bone. So that would be the concern or the problem. But the first place to look is on a regular head and neck X-ray to see if the styloid can be identified. We can always see it if we look for it on serum fluoroscopy as well, because we can change the angle an infinite number of ways. So that's another place we could let you know that you had an elongated styloid or you didn't. Now be careful there, because an elongated styloid is found in, again, a lot of people who have no problems or symptoms of Eagle syndrome, which is what we're talking about there, where you've got compression of that stuff. So not all that important unless there's other components of Eagle syndrome. The biggest one I think that might help differentiate that from other things is some of the throat type problems. And then that can be done with that glossopharyngeal nerve block to see if that goes away or if those throat problems are related to the neck. Adina, how about accessory nerve? Can potential compression be tested of the accessory nerve? You can do an accessory nerve block for sure, and that's how that would be tested. Wendy, can you do more videos on loss of cervical lordosis? Would like to see some real life case studies of people whereby we can see their symptoms, how they got diagnosed before and after treatment. Sure, Wendy, we can certainly do some ones on loss of cervical lordosis. In general, look at what that can mean. I think that would be a good video series to do. So I'm not quite sure when we'll get it done, but that sounds like a really good one. Levon, if there is IJV compression, will that lead to accumulation of CSF in the brain, which could lead to headaches? It's all possible, but Levon, I want to make sure that you realize that none of the patients in the study that I showed you who had IJV compression had any headaches or other symptoms of intracranial hypertension. So again, it could lead to a backup of CSF and a headache sensation or fullness, but the mere presence of IJV compression on a CT venogram or arteriogram does not mean that we found the diagnosis of intracranial hypertension. It just means we have IJV compression, which is pretty common in normal people walking around out there. And that's Carla's information in case you didn't get it before, ksalas@centenoschultz.com. So if you're interested in booking anything, she's the person to reach out to directly. What about orthostatic hypotension can be caused by cervical instability? Yeah, that's a whole other lecture, and I think a good one to go into. So I'll start thinking about how to put that one together too, is how orthostatic hypotension can be related to upper cervical instability, because that's that vagus nerve that we were just talking about and looking at, and how you can get that nerve banged into as well by C1. Toscana, I sent my MRI to y'all a couple weeks ago, hoping you can help me. Yeah, so Tosca, why don't you reach out to Carla directly? So this is Carla's information there. And just reach out to her directly, because I think she can make things happen quicker. So ksalas@centenoschultz.com would be the person to reach out to so that we can troubleshoot and make sure we get you the attention you need. Bert, can you talk next week about EDS and neck problems? Sure, we can talk about EDS. Again, Bert, I'm not quite sure what I'm going to do when. It depends on how much time I have. But that sounds like a great one to put on the list of things to discuss. EDS and CCI, EDS and neck problems in general. So that would be a really good one to do. So I'll add that to the list for sure. Adina, can we have intracranial hypertension but symptoms only in the occipital area? Generally, that's not what intracranial hypertension looks like. So the headaches that go with that tend to be pulsatile. They tend to have a fullness in the entire head. And if it's just pain back here, there's much more common things that cause that. So let's look that up here, because I think that's an important one, because this one I've gone over a couple times, and I want to make sure everyone understands this. What is in a proper headache workup? And that's something that, regrettably, if you've gone the neurology path, and oftentimes some of these surgical paths, those guys don't understand an injection-based diagnostic workup for headaches. So, or at least few of them do. So we're going to go and share the screen, and I'm going to pull this up. So this is that blog I keep referring back to. So it's on the Progenics blog. What is a proper diagnostic block headache workup? And you can see here that these are all the structures that can cause pain in the head that are in the neck. So look at all of those different structures, right? We've got 3 different facet joint levels. We've got multiple branches of the occipital nerve. We've got the superficial cervical plexus. We've got supraorbital and trochlear nerves, the auriculotemporal nerve, the C2 dorsal ganglion, the C2-3 disc itself, the sphenopalatine ganglion, and many muscle trigger points. So you have to be careful. For occipital pain, these things much more commonly cause occipital pain than intracranial hypertension. And here's a good example here. If we just bring this up, these are where the upper 3 facet joints refer their pain. So you can see here, if you've got pain directly under the skull, that tends to be more of the C1, C2 facet joint. These are the joints in your upper neck. The ileno-occipital joint goes in this type pattern, and the C2-3 joint goes in this type pattern. So right there, we've seen 3 causes of occipital pain that have nothing to do with intracranial hypertension at all. Tosca, I have Eagle syndrome. It's very painful, especially since I'm an opera singer. Yeah, so Tosca, we would certainly be happy to look at all that different stuff and let you know what we think. Cian, bioaccelerator in Colombia, treat neck ligaments? No. Yeah, we're talking about the difference between here and here and levels of expertise. Bioaccelerator would do very simple injections, so very low level care with regard to what we're talking about here. They would not have experts that understand any of this stuff at all. So that would be not a good place to go. As far as paying athletes to to sing your praises, that is what that is. But as far as what we're talking about here, no, that would not be a good match at all for what we're discussing. Floyd, thanks, Floyd. Roger, have you compared imaging pre-PICL and post-PICL that shows PICL reduces IJV compression? If so, does it correlate improvement in symptoms? Yeah, Roger, so that's something we've never been asked to do. Certainly be happy to do it if I could demonstrate that someone has IJV compression causing symptoms. So again, Roger, I want to make sure that we're clear here. IJV compression generally does not cause symptoms. I want to make sure I say that again. Based on the literature, IJV compression can be a normal finding on the CT venogram and does not generally cause symptoms. Now, the corollary to that is that some IJV compression probably does cause symptoms. The problem is finding out which. So I wouldn't know if that person had symptoms related to IJV compression or not. I could certainly document whether or not they're still getting IJV compression, let's say with movement, i.e. turning their head, but that's not what I've been asked to do yet. So haven't looked at that one. Steve, can you show MRI of the IJV areas in any EDS talk too, like syrinx seems to be common for very severe, I do EDS many times, give me a review. Wouldn't be MRI, it'd be more CT scan, but happy to talk about that in that context. Greg, I've been talking to ISIS, we'll also talk to Carla. Yeah, I'd reach out to Carla directly. I think we can speed things along if you do that. Goldie, Angie, so if you have a pretty severe compression of your IJV between your elongated styloids and C1, does it make sense to try PICL procedure before trying to move the elongated styloids? Yeah, Angie, that's the general idea. So again, we want to make sure that we first say that IJV compression is a normal finding that does not cause intracranial hypertension based on what's in the peer-reviewed literature right now. So that's the standard rule. Now, the corollary to that rule could be that you could be getting intermittent compression of the IJV and other structures, and that may be causing problems, in which case, obviously, we'd want to do the least invasive thing, which would be treating those upper neck ligaments through injection. And if that didn't work, you could always get the styloid removed, but removing the styloid is dramatically more invasive than doing a PICL procedure. So you wouldn't want to start with a more invasive procedure because that's just a prescription for exposing yourself to more risk than you need to. Sion, what's the success rate of PICL compared to neck fusion? I think it's pretty similar based on what I've seen. I mean, the biggest problem we see with neck fusion are the complications. So we don't have those kind of complications with PICL. So for instance, the biggest, I've probably treated a dozen patients now where they've put the screws too far through C1, C2 into the C0, C1 joint. So that's a good example, or the C1, C2 joint hasn't actually fused. So none of that is happening. As far as success rate, probably pretty similar between the two populations based on what I've seen so far. Okay, so I think we're at the hour mark here, and I'm going to start winding this down. I really appreciate all the great questions about IJV compression. Again, I want to make sure that people understand what it is we're talking about here, and that is that the research shows that IJV compression can be a normal feature and an incidental finding on a CT venogram. And it doesn't have to be associated with symptoms, and probably most of them out there are not causing symptoms. And that's because of collateralization, meaning that other veins build up around that blocked area so that the flow isn't disrupted. Now, we probably do have some patients that do have symptoms from IJV compression, but merely finding a CT scan that shows IJV compression doesn't mean that you're one of those patients. And so we have to look at, do the symptoms match? And then ultimately, we can't tell unless we decompress that area and we see if your symptoms go away. So that's kind of the take home from today. And then Camille, Hi, doctor. Do you recommend Algo in London and Dr. Zebig CureCore for C012 instability? So again, I think as I've always said, I think those guys can do some excellent work in doing some simple posterior ligament injections and or injecting those upper cervical facet joints. And that's a great place to start. If, however, they can't, if that doesn't work, then the only place that does the PICL is here in Colorado. So that means that you need to come from Europe to Colorado to get that done. But that's a great place to start. Yes, Steve, we just showed severe stenosis bilaterally was present in 1 in 10 normal people. And a one-sided severe stenosis was present in 1 in 4 normal people. So I think that study's already been done. Okay, guys, thanks so much for watching today. I really appreciate all of your time. And if you've got any questions on scheduling, this is your contact, ksalis@centenoschultz.com. So take that down, or you can just go back to the video and get it. So I appreciate everyone's time today. And I will be here on Friday doing another one of these. I'll try to look at those topics that you guys threw out and see which one resonates the best and which one I can get together in time. But again, thank you for your time today and your attention. And I will see you on Friday. Thank you.